Hi, folks. Good afternoon. It's really great to be here, and thank you for the applause and warm introduction. It is wonderful to be back here at Princeton. I was a student here 13 years ago, and used to come to this seminar sometimes for the free lunches, and I understood, I think, about 20% of what people said. And I use that as kind of something to reach for, but, in terms of things that I could learn and ways to be. And so I'm delighted, excited, and a little bit, I'll try to, hopefully you all will understand more than 20% of the words that I say. I will do my best. And if you don't, I have pictures of adorable babies that you can look at along the way. And hopefully we'll talk about some interesting topics. I am really just delighted to be here and grateful for the training that I received here in the Office of Population Research that really sparked my own interest in and training for understanding the policies and systems level analyses that can inform the way that individuals live in their lives and the way that health is produced on an individual basis. So briefly, as an overview, I thought about how to do this talk in a way that would be interesting and informative to you and also relevant to current policy discussions, of which there are many, including new ones this morning with the naming of the new Secretary of Health and Human Services for the incoming administration. But first I'll do a little bit of motivation about population health and policy context for the topic that I'm going to discuss today, basically why I do the work that I do. I'm going to touch on 3 different empirical studies that inform some of the policy discussions that I've been a part of related to birth and how we do birth in the U.S. And then take a few minutes at the end to talk about the road ahead and policy solutions that are implied by our empirical studies and are being discussed that may focus on several different levels. They may focus on, clinician patient interactions. They may focus on hospital level policies and clinical strategies to address solutions, as well as broader health systems reforms and changes, and even broader than that, political, social, cultural, and environmental factors that impact the systems and processes that happen on individual interactions and on interactions that individuals have with healthcare delivery systems. So I also I really welcome your questions and feedback along the way. I am concerned that I have potentially prepared slightly more slides than we may have time for, so we might need to skip around. You'll have access to any of them that you'd like to see later as we move ahead. But please do ask questions as they come to you. I look forward to having a discussion with you about these topics. So I want to start out, and this may be a little bit unorthodox, but I want to share with you my research mission statement, why I do what I do. So I believe that how people give birth and how babies are born is fundamentally important to health and well-being. This is something that became apparent to me when I began research, and also as a classroom teacher. I was a Peace Corps volunteer in Mozambique, where I was a junior high school teacher, and then was later a junior high school teacher in Minnesota. And the challenges that I saw adolescent girls facing in Mozambique and in Minnesota were part of what motivated me to understand policy and population health dynamics. I conduct research now to inform the development, implementation, and evaluation of health policy that impacts reproductive age women and their families. I study the impacts of institutional and government policies that affect healthcare delivery, quality, and outcomes during pregnancy and childbirth, but also over the life course. And I focus my research on groups that experience disproportionate vulnerability, but also groups that show disproportionate resilience. And I think looking at both the vulnerability and the resilience is important in studying different populations, including communities of color, low-income women, and rural communities as well. So I have been accused of studying a niche topic, birth. I would argue that birth is not a niche topic. In fact, I would argue that we are all born. We all come out in one of 2 ways, generally, and the exit strategy that we take at birth matters for us and for our mothers. And yet, this is a study that was published in 2016. The headline here, "Your biggest C-section risk may be your hospital." This headline, this is by a really great and thoughtful health journalist who was pulling together evidence that includes some of the work that we did that I'll talk about today. But the greatest predictor of pregnant person's chances of having a cesarean delivery is the hospital, not the clinical conditions that a pregnant person has, but the hospital where they deliver for those that deliver, or maybe we should say setting of birth, because not all deliveries occur in hospitals. So this is the trajectory of cesarean delivery from the 1990s to the present. This is a wild shift in how we gestate and give birth to humans in our country. You can see here the line on top with the squares is the overall cesarean delivery rate. The line just below that is the primary cesarean delivery rate, so first-time cesareans. And the curved line that goes in an opposite direction is the vaginal birth after cesarean delivery line. So both first-time cesareans and repeat cesarean deliveries are contributing to this really substantial shift in surgery at the time of birth. And I think one of the things to remember about this is that these shifts are pretty seismic. 1% of people that give birth is 40,000 people, because we have about 4 million births a year. This is just huge. During this same time period, the average gestational age of a fetus in the United States, or of a baby that was born in the United States, decreased by 1 full week. So we've gone from an average gestational age of 40 weeks to an average gestational age of 39 weeks, which has to have, again, broad population health implications for neurological development and a variety of other things. So those aren't my specialties. I'm a health policy researcher. So why am I talking about birth, which, again, I fundamentally believe is important, but in my field, why are we talking about birth? So in a policy context, in healthcare policy and health services research, cesarean delivery is important because it's the most common inpatient surgery in the United States. Also, hospital charges for maternal and neonatal care exceed those for any other type of condition for both public payers and private payers. So health plans, both public and private, are paying more for maternity care and newborn care than any other service line in a hospital. Nearly half of all births in the U.S. are covered by Medicaid through public health insurance. So we as taxpayers are financing the healthcare delivery system and or are financing the provision of healthcare delivery at the time during pregnancy and at the time of childbirth for almost half of all births. And this is something, so the cesarean delivery rate. So I've done a lot of work on cesarean, and I think it can be a polarizing topic. And there's pretty wide consensus in the clinical community now that our current rates of cesarean delivery are above an optimal level of what would be required, what would be needed based on medical conditions. I believe cesarean deliveries save lives. I spent enough time working in Africa that I know that access to emergency obstetric care, including access to safe cesarean delivery, is extraordinarily important and should be a human right. So should be the right to not have a surgery that is not necessary. So getting that balance right is difficult. I'm not a clinician. I don't have to make those decisions every day, but I hope that the data that we crunch and the work that we do helps inform the decisions that clinicians make and helps clinicians work in systems that help them, that guide their decisions in ways that are consistent with optimal patient care. So in terms of our kind of national goals around this topic, the Healthy People 2020 goals call for a 10% reduction in both primary and repeat cesarean delivery rates. So we're starting to create national public health goals that reflect medical knowledge around the overuse of cesarean delivery. So, oh sorry, was that jarring? That's not a cute baby, is it? I should replace the photo. A lot of us don't know. I've been asked a lot, pretty much on a daily basis, both by the questions in my own head and by my students. What's going to happen? How is your research going to change? what's next for policy writ large, I think what we knew before yesterday and what has been confirmed even more so based on the intent to nominate Representative Price as the new Secretary of Health and Human Services is that the future of Obamacare has a terminal diagnosis, but no prognosis for the way forward or how that's going to look. But I expect that the way that the Patient Protection and Affordable Care Act, the current infrastructure of that, there's both a kind of a political and an ideological imperative to make some pretty substantial changes to that. However, I do think that there are some things that we can garner from the information that's known. One is that value will be increasingly important in policy decisions. The decision, for example, to block grant Medicaid will restrict funding that's available and make it very important to look at high value services. So spending on overuse of a surgery for a common condition like birth is actually a place where there may be some receptivity to making shifts in policy changes. I also think people will likely keep giving birth, and that the costs of childbirth will continue to be shared by families, employers, and also by taxpayers. So there will be a role for policy in this topic. So why do I do this stuff? I think that I believe that evidence can and should inform policy. That the research that we produce as academics can help policymakers make decisions, but it's on us to communicate well about the research that we're doing, both when we are planning the research and in thinking about the questions that we'll ask, and in finding out the results and thinking about what they mean. And so we know that the use of evidence in policymaking is influenced by the media, by the message, by the messenger, and also by its relevance. And I think what we can do to be more effective in this space, especially now, I think as there's a lot of major shift that's going to happen around health and healthcare policy in this country, is to communicate our findings to policymakers in a way that is relevant to them and the decisions that they have to make, which includes budgetary decisions and so forth. And also taking account of policy realities in our research to, again, try to increase the relevance of what we're doing. So a research question that we asked in a study that was published, it's listed here in 2013, was how do cesarean delivery rates vary across hospitals in the U.S.? This is not the most rigorous study I've ever done. In fact, it's quite descriptive and includes very little multivariable analysis. And it made the front page of the New York Times. And so it's a good reminder that those rigorous methods, I'll show you a paper in a minute that has more rigorous methods because that's required and important as well, but that both our descriptive work, again, being careful not to extrapolate more causality than is intended, but also the kind of more precise statistical gymnastics of using data to try to understand truth, both are important. So studying variation in procedure rates is something that is quite common in healthcare policy. Folks do it all the time, and they frequently do it with Medicare data, which means that the many of the studies that study variation in procedure use, the fabulous work that's come out of Dartmouth and the Dartmouth Atlas Project, a lot of that focuses on conditions affecting older adults and doesn't commonly include women of reproductive age. Studying variation is important because it indicates either overuse or underuse of procedures and a potential quality issue, and also an opportunity for capturing value that's not currently being captured by the system. So briefly what we did, so as I go through these empirical studies, I'm going to be a little bit breezy in how I go through these. The studies I'm talking about today are all published, so you can see the details of them and feel free to ask if you have questions, but I want to tell you a little bit about kind of what our findings were and how they fit into this broader policy context. So we used national hospital discharge data for this study from 2009. This is a great data source, by the way, for those of you that are interested in hospital-based conditions. It's available for quite cheap and is great also for student projects. So we used hospital discharge records for a 20% sample of all U.S. hospitals, and we analyzed hospital cesarean rates, basically what percentage of all deliveries at your hospital were by cesarean, and we also looked at what percentage of all low-risk deliveries in your hospital were cesareans. And we did a descriptive analysis and made turnip plots. So I mentioned overall cesarean delivery. Our low-risk measure was the rate of cesarean deliveries for women with term, singleton, vertex pregnancies, and no prior cesarean deliveries. And this is very consistent with the AHRQ measure for low-risk cesareans, but it doesn't include the nulliparous women, which a lot of other measures do, and that's not information that was available in hospital discharge data because parity is not coded in billing data for hospitals. So if you want to look at what we found, our visual display of data, I love these. I love turnip plots and displaying variability in this way. And in fact, one of the things I'll argue toward the end is I think we ought to be displaying data this way more often because averages mask disparities. Averages mask variability. If you look at the average, which is what I showed the average over time at the beginning of this, you don't see that in the United States there are hospitals with a 7% cesarean delivery rate and two hospitals, in fact, with a 70% cesarean delivery rate. The 7% is quite an outlier at the bottom, and you can see that. The 70% is not, however. It's not that there's just one hospital. There's a handful of hospitals up there. I will also mention that these are all hospitals with at least 100 deliveries in 2009, so you're not seeing it swayed considerably by small delivery volume hospitals. We also did stratify by delivery volume to look at that, and you see variability across strata in terms of hospital birth volume. When we look at the low-risk cesarean delivery rate, what we want to see is less variability, right? Because this is a risk-adjusted sample to some extent. And it is somewhat squeezed. Those blue dots don't show up very well there. Forgive the blue dots. But you still see variability from about 3% to 36%. So this is 15-fold variability in hospital cesarean rates for low-risk women. So we found that hospital cesarean rates vary substantially. And as I mentioned, there's a 15-fold variation in low-risk cesarean delivery rates across U.S. hospitals. Our conclusion was that large variations around increasing cesarean rates indicate that differences in practice patterns may be driving costly potential overuse of cesareans in many U.S. hospitals.
Are there certain kinds of hospitals, like private hospitals, or like Cook County, the county hospitals that have a lot of Medicaid patients that would do this or is there also state variation? Because that's what you're going to see a lot of state variation in Medicaid coverage.
Correct. Yes.
Reimbursement rates.
Yes. The variability was across all strata. So there's variability among private hospitals, among nonprofit hospitals, among hospitals that are predominantly Medicaid funded births and those that are predominantly privately funded. We've done separate.
Variation?
It's quite similar across groups. There's really what I'll show in a little bit is looking at patient risk factors. We have another paper that looked at payer, and we found that when the primary payer is a private health plan, your chances controlling for all clinical characteristics and diagnoses, that your chances of having a cesarean are higher than if you have a Medicaid-funded birth. And the lowest rates of cesareans were for uninsured women. And the reason for that is payment, because private health plans, so cesareans deliveries are paid about twice as much as vaginal deliveries, and private health plans pay about twice as much as Medicaid plans. And so there is a financial incentive there. And that's not to suggest that any clinician, any obstetrician is taking those individual decisions based on payment. I don't think that's true. However, they're working in hospital systems that understand their payer mix and that shape their management policies and practices within their labor and delivery unit based on those financial realities. And I think it's particularly harsh in obstetrics as a service line, which is kind of a loser, a loss leader for hospitals. People don't make money on obstetrics, generally. So the big question is why, right? P.S. If you Google confused doctor images in Google Images, there are a lot of pictures that you can come up with. So a lot of discussions here, and I actually don't even have payer mix on here, but that was one of the other things we investigated. I'm going to talk about the first two here, patient case mix. One of the obvious things is different hospitals have different patients, and you would expect variability, and that would be appropriate if there were a hospital that specialized in high-risk pregnancies, and everyone that needed a cesarean was referred to that facility, and that's where you saw a 70% cesarean rate, I would be delighted to see that. So we actually did a more rigorous analysis that I'll show you here. And then we also looked at maternal support from a doula, which is non-medical support, and I'll talk a little bit about that in its association with cesarean delivery. We've done a lot of rural and urban analyses as well. One of the focuses of my work is on rural communities, and specifically on maternity care and maternity care access and quality in rural areas. And is there something else about hospitals or something else about policy that's shaping this as well? So this was the title I wanted to give this paper that we published in 2014 in PLOS Medicine. This is the paper that I have never responded to so many comments from reviewers. I had 8 different reviewers, 2 different academic editors. It was an international journal, and many of the reviewers for this paper were from international contexts. And so I worked these data so many times over because they were like, that this can't be true. It can't be possible that patient characteristics aren't what is explaining this variability. So I'm fairly confident in these results. I've never gone through a process like that, and it ultimately wound up to be really great. I do have a limitation slide that I'll show you in a few, and the person who was the academic editor for this piece wrote a commentary that accompanied this manuscript that talked about the limitations of our data and some of the weaknesses of it. So if you want to, I'm happy to I would freely admit to all the limitations of this analysis, of which there are many. But so there's a lot of debate about, how do we really get to understanding this. Our research question was how much variability in hospital cesarean rates is explained by patient conditions. And while I would love to take credit for the beautiful analytics in this study, Mariana Arcaya was the woman who led the hierarchical modeling for this, and Subbu Subramanian, who's also works in this at Harvard. The two of them, Mariana was a postdoc at the time, and they called me after the publication of the first paper and said, "But you did this really wrong. It's just a descriptive. Let's get into the data." And so we worked together on this paper, and that collaboration came out of their interest in and desire to extend and expand upon what we had done in our descriptive study. So I'm really grateful to them. We used the same data source that we used for the prior study, and had almost 1.5 million births in almost 1,400 hospitals in 46 states in the U.S. We measured our variables based on ICD-9 procedure and diagnosis codes primarily, as well as other administrative data. We had a whole series of complications of pregnancy, labor, and delivery that were coded with ICD-9 procedure codes and clinical classification software codes. There are a lot of limitations to coding data and to using administrative data. However, in birth, payment for births is often risk adjusted, and so higher risk conditions are more consistently coded in billing data for births because, as I mentioned before, hospitals want to make sure that they are getting all of the money that is due to them for handling complex cases, and so we feel fairly confident that many of these complications are indeed present in the data. We divided the study into different risk groups. Again, we went round and around, and I've defined these in many, many different ways. One is looking at all births. Secondly is looking at primary cesarean, which here is defined as all births to women without any prior cesareans. So it's not necessarily their first birth, but we know they have not had a prior cesarean. Lower risk women were all births to women with term vertex singleton pregnancies and no prior cesareans, which is similar to the same as how we defined it previously. We also looked at a higher risk group of women, births to women with pregnancies that were preterm, non-vertex, multiple gestation, or delivery after a prior cesarean. These are some of the key predictors of having a cesarean delivery. Now, having a prior cesarean does not require that you have a cesarean, and so we went back and forth about this definition. And again, I've done this a lot of different ways, but I still want you to see sort of these high-risk groups. I'm going to present now the funnel plots that we put together for this, which were really interesting. So, hospital cesarean rates for each of the 4 groups that were described above what we show here is the outcomes in the context of precision, demonstrating how the institution, so each dot is an institution, each dot is a hospital. How do they perform compared to control limits, which are 99% prediction intervals around the calculated mean? And so what you can see here is the number of hospitals that fall outside the 99% prediction interval. This is pretty wide dispersion based on what you would expect. And so, for example, in let's see, I have a, there we go. Figure A here is all cesareans. This is the primary cesarean. So again, you've got an average that's lower. This is the low-risk cesarean. Again, a very similar average. And this is the high-risk group. You still see, look at this variability in the high-risk group. Some of the variability is because you've got smaller denominators here, but still we've got a 99% risk prediction interval. And it was, this variability, especially among the high-risk pregnancies, was really quite striking. So based on chance, we would have expected 70 hospitals to sit outside the bounds in the overall births, and what we had was 541. And this is after adjustment. So the analysis was, as I mentioned, not mine, but brilliant. I can speak to Mariana's brilliance. What we had is we show null models. So this is just overall unadjusted variability, and then a measure after adjustment for patient characteristics and state fixed effects. So we did, and we, with or without state fixed effects, we included a variety of different models. The ones that were ultimately shown here are those without or with state fixed effects included. So this is so this shows for each of the four groups, each of the four risk groups, what was the unadjusted model, the variance, the variability, and this is after adjustment. The variability is expressed on a logistic scale, so it's 0.13. So that means that the 95% credible interval around here excludes 0. Okay, so expressed as a percentage of the risk for an individual's risk of cesarean delivery. For the first one, the average risk of cesarean overall for women varied between 19% and 48% across hospitals after adjustment. And the other thing that you see is that with adjustment, this doesn't go down and it doesn't statistically change. There's, it looks like it even in low-risk women, it looks like statistical adjustment for clinical covariates actually increased. I mean, not statistically so necessarily, but it's really striking. The only place where risks did go, or the variability, the measured variability across hospitals did go down after risk adjustment was in the high-risk women group. So that was good to see, and yet the variability that remained, again, we've got a 0.25 here, which is greater variability than you saw in the all birth sample. So, there we go. Apparently, so now they're highlighted in red boxes, if you would like to see that. So, again, so the words are here to try to translate these numbers a little bit around an individual risk. And again, a person with exactly the same clinical characteristics in hospital A versus hospital B, their risk varying between 19% and 48% of having a cesarean birth. So our key findings, some of these are very similar to what we found before. We have a point estimate for variability, but really this main implication is that variability in hospital cesarean rates is not driven by differences in patient clinical characteristics or patient complexity. This is really challenging information to know what to do with. As I mentioned, there are a lot of limitations in this analysis, many of which are detailed pretty extensively. I think limitations, they make babies really sad, so we should try to not have them, but they do happen. So our results indicate this greater between hospital variability in cesarean rates among women with no prior cesareans. And this around the same time, it was about, I think, our study was published a couple of months after this consensus document came out. So this was the obstetric care consensus document on safe prevention of the primary cesarean delivery, focusing on the first cesarean that came out of the American College of Obstetricians Gynecologists and the Society for Maternal Fetal Medicine. And one of the implications that, or one of the recommendations that they have is a focus on more consistent management of some of labor and of labor conditions. And I think that that's really warranted based on the results that we have, because what you saw is that for the same clinical condition, there were different management strategies in different hospital settings. And so I think that our results really are highly consistent with what you see in terms of clinical guidelines and recommendations for what is needed to move ahead. They also recommend external cephalic version for breech babies, trying to manually turn the baby, and trial of labor and trial of labor for vaginal birth for twin births without any other risk factors. And again, these are things where we saw variability across hospitals in our study.
Do you have any information on whether the hospital has sustained a certain number of suits? Like obstetricians are having a lot of problem because of lawsuits, and so the share of physicians that want to go into the specialty is declining because of these suits. So do you have any information about suits in particular hospitals?
Yes, that wasn't a part of this study. Others have done, my colleague Tony Yang at George Mason University has done a number of studies on medical liability and on the relation between medical liability, specifically looking at state laws and practices around medical liability and state cesarean delivery rates. So it was looking at which is a more, it's a more ecologic kind of analysis, but found that the medical liability and the lawsuits explained some but very little of the variability in cesarean delivery. So there is something to that, and it's the first thing that physicians often say when we're talking about this topic. It's a very salient thing, but empirically we haven't seen that explaining a large degree of the variability. Also, I'm not convinced though that our measurement is very good or very precise on that. So, dissertation topic, anyone? So, even excellent new clinical guidelines followed diligently by individual clinicians may not be enough, because an individual clinician that wants to offer external cephalic version for a breech baby, or that wants to try a trial of labor for twins, may work in a hospital institution that doesn't have a policy that allows that. They may be willing to provide vaginal birth after cesarean delivery, but many hospitals themselves disallow that. And so I think we often think of the clinician as an independent agent, but they are in fact constrained by the policy environment that they're working in, both the payment environment and the hospital administrative environment that they're working in. So I think that it's important to consider non-medical factors, systems level factors, and broader cultural and political forces that are shaping the environment in which pregnant people and their clinicians make decisions about delivery mode. So that brings me to kind of a different topic, but turns out to be quite related, which is looking at doula support and looking at doula support being associated with lower rates of non-indicated cesarean delivery. So raise your hand if you know what a doula is. Oh, okay. This is so exciting. I've been working on research related to doulas for a number of years now, and the first time I used to ask that question, and there'd be like a couple of sort of birthy folks that were like, "I know what you're talking about," but not very many. And last year I gave a talk. It was about a year ago now at the Medicaid Health Plans of America conference, and I asked that question. It was a plenary, and so there was a big group of people, and I said, "How many people know what a doula is?" And 90% of the room raised their hand, and I get chills just thinking about it. I was like, wow, that's amazing that there's been greater awareness of this. And I'll show you a little bit why, kind of empirically, I'm getting excited about that. A doula is a trained and experienced professional who provides continuous physical, emotional, and informational support to the mother just before, during, and after birth, or who provides emotional and practical support during, and I'll say pregnancy and the postpartum period, because a lot of doulas meet with and support their clients during pregnancy as well. An important distinction is that unlike clinicians, physicians, midwives, and nurses that provide clinical care, medical services, a doula provides support in non-medical aspects of labor and delivery. So it is a complement to, not a substitute for, any medical services. Doulas they make no medical decisions, they don't evaluate any medical conditions, and that's, their role is entirely non-medical in terms of the support that they offer. In the same Safe Prevention of the Primary Cesarean Delivery document that I mentioned earlier that talked about management of labor, there was a statement that was listed in there that describes the use of doula services at the time of childbirth. And again, this is from the obstetricians and the maternal fetal medicine docs. Published data indicate that one of the most effective tools to improve labor and delivery outcomes is the continuous presence of support personnel such as a doula. It describes the Cochrane Collaboration meta-analysis of 12 trials, more than 15,000 women, and it showed a lot of positive outcomes, greater patient satisfaction, lower rates of cesarean delivery, higher rates of spontaneous vaginal birth, shorter labors, lower rates of epidural use, lower rates of episiotomy, lots of things that are broadly associated with better birth outcomes, lower costs, and the statement was included in this, that given that there are no associated measurable harms, this resource is probably underutilized. So the clinical evidence is very clear around doula support. So why doesn't everyone have one if it's so clear? And the answer, does anyone know? Who's going to pay for it? Yes, that's exactly right. So a couple of things. I think the barriers to access to doula support are threefold. The first is financial. Most doula services comprise about 3 or 4 visits during pregnancy, support during labor and delivery, and one or two postpartum visits. And that typically costs between $900 and $1,300. The average savings for a family at the time of first birth in the U.S. is $5,000. Do you think they can spend 20% of their savings on something when they are looking down the pike of spending as much as they'll be spending on childcare, on diapers, on all of the things that are expenses that are associated? And out-of-pocket costs for childbirth for people, especially in people in high-deductible health plans, have also increased dramatically. So the first barrier is financial. The other 2 barriers are cultural and geographic. Most doulas are white upper-middle-class women who support white upper-middle-class women. Not all people who give birth are white upper middle class women. In fact, half of them are people of color. Also, most doulas are located in urban areas, and about, it's 500,000 births a year happen in rural areas. So there are a lot of people that simply don't have access. I'm going to describe one of I've done a number of studies on doulas, but I want to describe one of them that was a little bit more, that sort of got at the issue of selection bias a little bit more, because obviously people that choose doula support, when you're going to look at outcomes for people that have a doula and people who don't, people that are willing to pay for a doula and actually seek one out are quite different in terms of the outcomes that they hope for. So of course there are going to be lower cesarean rates. That's selection bias, right? So I get that. I've heard those criticisms. And we were actually able to do a study to try to look at desire for doula support as well as outcomes. So we looked at the relationship between doula support, desire for doula support, and cesarean delivery, distinguishing cesareans without a definitive medical indication. The data that we used for this study was the Listening to Mothers survey, which is a nationally representative sample of women who gave birth to a singleton infant in a U.S. hospital between July 1st, 2011 and June 30th, 2012. There are 2,400 women in this study sample. These are publicly available data through the Odom Institute at UNC, so if folks are interested in doing research on this topic or on birth generally, this is a really rich and nationally drawn data resource. So the questions about, so I'm going to pause for just a moment to say the questions that were asked, this is one of the only surveys that asks about doulas. It says kind of first of all, did you have support from a doula? And people say yes or no. You'll see about 6% of women in this survey reported having doula support. Then they say, to the people that didn't have support, they say, do you know what a doula is? And some people are like, yes, some people are like, no. Of the people that say, yes, I know what a doula is, they say, would you have liked to have had a doula? Were you interested in that? And then people could say yes or no. So you could see if people were, were aware of what a doula was or not. And of those who were aware, how many of them would have liked to have had that type of support. Now, how strong that desire was, we don't know, but it does start to get at the differences between people that would desire this type of support and those that would not necessarily desire this type of support.
Lamaze, training qualified for doula?
Lamaze does not certify doulas. There are a number of organizations nationally and internationally.
It can't be certified. It can't just be your local curandera.
So there are. You can. I mean, anybody could support another person in birth, and there are certainly a lot of traditional practices. This is something that I've learned about in the community-based work that I'm doing, but certification is a part of the process for most of the people who call themselves doulas, and from a policy perspective has been important for quality assurance for payment. So interestingly, we have a number of covariates. There was a question in this survey that said, do you agree or disagree, or how strongly do you agree with the statement, birth is a natural process that should not be interfered with unless medically necessary? So this allowed us to control in this analysis as well for people's preferences for natural childbirth or beliefs about childbirth, which again is very important when your outcome is cesarean delivery, in terms of really capturing substantive differences that may be intertwined with selection bias issues. So our analysis was a multivariate logistic regression analysis. We had two comparison groups. We compared women with doula support to those without doula support. And the second comparison was women with doula support versus those who desired doula support but did not have it. So we did both of those comparisons in the analysis. And let's fill in the chart. So this is comparison one. And you can see the N values here of women who had doula support and those who did not have doula support. Comparison two looks at the women who were aware of doula care and desired doula care and compares them with women who had doula support. So you can see how we're comparing two different populations here. So comparison one tells us information about who does not have doula support. It turned out that women that were 25 to 29 and over 35, so the older mothers, were less likely to have doula support than younger mothers. Those 18 to 24 were more likely to have doula support. Experienced mothers were less likely to have doula support versus first-time mothers, and that's consistent with what is kind of commonly known in the very small doula literature. Also, women whose pregnancies were unintended had lower rates of doula support compared with those who had intended pregnancies. Using comparison two, who doesn't have doula support and wants it? This is very interesting. Women with public or no health insurance coverage compared to those with private coverage. And this is a direct proxy for income because income eligibility is kind of what qualifies you for Medicaid or public health insurance during pregnancy. They're almost twice as likely to have said they wanted a doula but didn't have one. Women having a planned cesarean delivery. Doulas can't, so the point of a doula is not to prevent a cesarean from happening, but to support someone in the birthing process. And also black women, compared with white women, were much more likely to say that they wanted a doula but didn't have one. So does having a doula really affect the chances of having a cesarean? Briefly, yes. We found a 60% reduction in the odds of overall cesarean delivery associated with doula support. What was interesting to me is we had done a prior study using hospital discharge data compared to a community-based sample of doulas, and we found a 42% reduction in the odds of cesarean delivery. So this is and some wide confidence intervals around that, but this is consistent in a totally different sample, collected by a totally different methodology. And so it was good to see that kind of level and consistency across data sets. We also saw an 80% lower odds of non-indicated cesarean delivery compared with not having doula support. So this is comparison one. You immediately say selection bias, right? Okay. Is it just because women who want doulas are different? And what we found was no. When we compared women who had doula support to those who had a desire for doula support but didn't have it, those women with doula supports had lower odds of cesarean delivery, and again, we got a 70% reduction, so it's actually, again, point estimate a little bit stronger, but statistically similar. So what we found is that it was the doula that made the difference, not the desire for doula support in this study. It should be replicated and in other samples and so forth, but really was interesting to see this. So key findings, which I've already discussed, but the important implication here was that increasing access to doula support may facilitate decreases in non-indicated cesarean delivery rates. For those that desire doula support, having that, and again, following on the clinical guidelines and recommendations from obstetricians and maternal fetal medicine specialists, that seems to make a lot of sense. Again, a lot of limitations here. There's recall bias, social desirability bias, timing of the questions. Those make the babies so sad. You can read the limitation section of the paper, but what I want to make sure that we talk about and have a little time for discussion around is the way forward. So I have some thoughts that have emerged from some of the empirical work that we've done on both quantifying variability in cesarean rates and understanding the forces that drive that variability, and the lived experience of people who are giving birth, and also the population level implications of that. So I think we have work to do on maternity care measurement, quality measurement in maternity care, healthcare systems reform, and social determinants of poor birth outcomes. There's been a lot of activity around maternity care measurement lately, around developing quality indicators for maternity care. There are a number of measures that have been listed here, and a lot of debate about that. Here's my question. Why aren't we measuring variability instead of average rates? If we are only looking at averages, we are missing the ball, and we are missing opportunities to look at if we've got overuse, if we've got underuse, where it's occurring. And I think that ought to be part of the discussion. It's more nuanced, it's more difficult, but making a turnip plot is not the hardest thing in the world, and I would love to see a little bit more of that. If variability is used, how should rates be reported? So I've talked about hospitals as a unit of analysis, and I think that's very, very important. There are other predictors as well, and there are a few examples of where this is already being done. The state of New York has enabling legislation that reports hospital rates of a variety of different things. You can actually get hospital rates of midwife-attended births and breastfeeding, and a range of different data that are not always publicly available, and these are reported on the New York Department of Health website listed here. In Minnesota, there's an organization called Minnesota Community Measurement that's supported by the state Department of Health that has done provider group ratings, so based on the provider group level of cesarean delivery rates. Because some people choose their hospital and then choose a provider based on a hospital or birth setting that they would like. Others choose a provider or a provider group, and that's another way of providing information and increasing transparency around variability. There's been a lot of discussion around individual providers. Attribution is a big problem because there's a lot of changing of shifts during delivery and also transfer of care, so it's hard to know whether individual provider ratings would be useful. So a little bit about health systems transformation. A couple of issues have come up that we've in this discussion already around financing and payment for maternity care. There's been a lot of the Catalyst for Payment Reform has done a really nice white paper on payment reform in maternity care, looking at bundling payments for maternity care. It's a great example. We talk about bundled payments in a lot of different aspects of healthcare delivery. Again, a lot with Medicare data, but there's a pretty clear episode happening around pregnancy and childbirth, and it seems that it could be amenable to some discussion around bundled payments, also blended payment rates, and I'm doing some research right now on Medicaid programs that pay the same for an uncomplicated vaginal birth as they pay for an uncomplicated cesarean birth. So it's a little bit less for a cesarean than you would have gotten before and a little bit more for a vaginal birth, but doesn't provide a financial incentive for uncomplicated deliveries for doing a cesarean over a vaginal birth. Jury's out on that yet, sorry. Anybody who works with CMS data knows what happened this week. It's systemic failure of all of our data. It's a bummer. It's already kind of a bummer week, so that was hard. In terms of organization, integrated delivery systems and workforces that match patient needs. We talked about this a little bit at dinner last night, but the population of people giving birth, the risk profile looks like a triangle, where you've got a few very high-risk people and most people are low risk. The picture of the workforce that provides care for these individuals is an upside-down triangle with a lot of people. Obstetricians are trained surgeons. Most people that are giving birth are not expecting to have surgery. If we wonder why there are so many surgeries happening for low-risk birth, it's because we have surgeons caring for low-risk patients, and that's their training. And so I think, there's a need for more providers that specialize in caring for low-risk pregnancies. And lastly, accountability and equity. So I've already said this a lot of times. We're concerned about population health, but I'm concerned about variability within populations as well, and I think that's really important. Different people go to different hospitals. There's some fantastic work that's come out of Mount Sinai School of Medicine. Liz Howell is an obstetrician there, she also has an MPP, so she's a policy person, and has done some really interesting work on how much the hospital contributes to the black-white mortality, infant mortality gap in New York City hospitals, looking at the hospital that you go to. So black people are more likely to give birth in hospitals that provide lower quality care and have higher mortality rates. So even if you look at all the same characteristics in people that look exactly the same clinically, the hospital where you deliver matters for the outcomes of your birth. And advancing the imperative to address persistent disparities. So what are the prospects for health systems transformation in the, I don't have a jarring photo of the president-elect here to frighten you, but it's frightening nonetheless, I suppose, for those of us that have spent a lot of time working on, building from the infrastructure that was created by Obamacare, imperfect as it is. We're not sure what the foundation is anymore. But eliminating the essential benefits requirements, which seems to be a topic of discussion, will take maternity care out of many individual plans. And I think that's something that may affect how we talk about value, quality, equity in the space of childbirth care. Pre-existing conditions exclusion. So there's a lot of discussion about pre-existing conditions exclusions being possible for people that keep continuous coverage. About a third so pregnant people do not have continuous coverage. It is very, very rare. There is a high socioeconomic status group of pregnant people that tend to keep private health insurance throughout their pregnancies. But again, half of all births in this country are funded by Medicaid, and that means you move between coverage and you're not continuously covered, and there are gaps in coverage. It's also a time when people move and change jobs. About 30% of people during their pregnancies move locations, which may require getting new health insurance or getting a new job. So could a prior cesarean be grounds for exclusion or for higher rates? In the past, it has been, and that's the future I think we're looking at now. Gender parity in premium rates. So this is something that's protected. Men and women pay the same for their premiums under the Affordable Care Act. There's been a lot of discussion around age rating and changing that so that there's greater variability across ages and premiums. And I haven't heard as much discussed about gender parity, but I'm, if maternity care is taken out of most health insurance packages, by default, people who want to have health insurance that includes maternity care will be paying more for those packages, and those will likely be women or trans men. And I already mentioned Medicaid block grants, but I think that that's certainly a possibility that we're looking at and may require some innovative ways of thinking about value and in maternity care. And again, some of this is trying to think about what scenarios will play out and what research is necessary to inform the decisions that are being made to try to do the best that we can by people who are pregnant and by women and families and children. I think the long game here, outside of the specific politics of Obamacare or any other health policies, is addressing social determinants of health. We talk about this a lot, but what does it really mean? And I think it means disrupting the well-worn pathways between social determinants of health and poor birth outcomes. In this country, black women are 4 times as likely to die in childbirth as white women. And that has not changed for more than 100 years. We have changed a lot about medical care during that time. Black infants are twice as likely to die in the first year of life as white infants. That disparity is not narrowing. Rates of maternal mortality have actually gone up in the past generation in the U.S., but rates of infant mortality have gone down. The disparities have not. So we need to think outside of the medical realm when we're talking about how to address these, and we ought to start, stratifying our analyses and looking at black people by racial group, by other groups that, and I think racial groups, we have a lot of problems with measurement of race, right? It's really hard. And yet we see those disparities, and so we ought to pay attention to that. in a hopeful example of a few. This is kind of my last little bit about potential policy strategies. Like what does that look like in a policy strategy? And I think it can look like any of these three things. One is a role for doula care. So I showed you a study, one of my studies on doula care. We had a prior study. Again, it was quite descriptive and not as rigorous. But that study informed the development and implementation of a policy in the state of Minnesota in 2013 that allowed Medicaid payment for doula services. And that passed in May of 2013. Implementation began in 2014. It has been very difficult, but we have a law in the books in Minnesota that's allowing Medicaid coverage for doula services, and that access is expanding and growing over time. We're the second state. Oregon also has that. New Jersey introduced a bill a couple months ago on this, which was very exciting. So, folks, get out there and advocate if you want. The role for out-of-hospital birth. So there's, in attention to disparities, and I'm learning a lot from my colleagues with sociology training and backgrounds around conceptualizations of race and racism, and not interpersonal racism, but systemic and structural racism. And one of the systems and structures that systematically disenfranchises Black mothers compared with others, especially, but other racial groups as well, in particular American Indians, in my state, but is hospital-based childbirth and the medicalization of birth. And so the role for out-of-hospital birth in moving outside of those systems and structures is important. And there's a really great perspective by my colleague Neil Shaw in the New England Journal of Medicine that compares the U.S. and the British context around out-of-hospital childbirth that I'd recommend if you're interested in these topics. And more broadly addressing structural racism, my colleague Rachel Hardiman published a perspective in the New England Journal a couple weeks ago now on structural racism and supporting Black lives and the role of health professionals and what can be done, like literally what are the steps you can take if you're a health professional in research or in clinical care to contribute to dismantling structural racism as it affects people's lives and well-being. So this is my research mission statement again, which I told you before. I want to acknowledge all of the co-authors that are listed on these slides, my community collaborators. Princeton and OPR for sparking my interest in policy research. Yay, thanks James. And others. Noreen, thanks you guys, it's been a while, it's great. And also I want to thank my kids because giving birth myself was pretty helpful for guiding my own substantive knowledge of some of these topics. So the lived experience is important as well. Thank you for your time.